Hi, and welcome back to the Pro PA podcast. I'm Angie Urbina, your host for this cardiovascular series, where we're breaking down essential topics for clinical practice and PANCE preparation. Today we're tackling deep vein thrombosis, or DVT, a critical vascular condition that every primary care provider needs to recognize early to prevent life-threatening complications like a pulmonary embolism. We'll cover what DVT is, who's at risk, how to diagnose it, and what to do when you suspect a patient has one. So let's dive right in. Starting off with some basic pathophysiology, DVT is a type of venous thromboembolism that occurs when a blood clot forms in the deep veins, most commonly in the lower extremities. The foundation of DVT pathogenesis is venous stasis, endothelial injury, and hypercoagulability, which is called Virchow's Triad. Factors like prolonged immobility, recent surgery, malignancy, or inherited thrombophilias increase the risk of clot formation. If left untreated, a DVT can lead to pulmonary embolism, which is potentially fatal. A quick little mnemonic for Virchow's Triad is SHE, S-H-E. The S stands for stasis, the H for hypercoagulability, and E for endothelial damage. And so just to reiterate, for venous stasis, you want to think of prolonged immobility, long travel, polycythemia or pregnancy. For the hypercoagulability, you can think of things like malignancies, oral contraceptives, or thrombophilias. And for the endothelial damage, you can think of things like trauma, surgery, or prior thrombosis. Now, who is at risk for DVT? The answer is anyone with the right combination of risk factors, which we pretty much already mentioned, but it doesn't hurt to mention some of these common ones again. They are hospitalized patients, post-surgical patients, individuals on long flights or long travel, patients with clotting disorders, patients with cancer, oral contraceptive use or hormonal replacement therapy, and patients with prior history of a DVT. Clinicians should always be vigilant when these patients present with lower extremity complaints. Now, let's talk about how DVT presents. Classic symptoms include unilateral leg swelling, pain, redness, and warmth. However, not all cases are textbook. Some patients may only have nonspecific symptoms or even be asymptomatic. One key physical exam finding is larger calf circumference in comparison to the other leg. A palpable cord or dilated superficial veins may also be present. And a test that you may see on exam questions, although it is neither sensitive nor specific, is the Homan sign, which is where there is calf pain with dorsiflexion of the foot. Regarding diagnosis, the diagnosis of DVT starts with clinical suspicion. The Wells score for DVT is a useful risk stratification tool. If the score suggests a high probability of DVT, an immediate compression venous ultrasound with Doppler is warranted. If the Wells score suggests a low or moderate probability, then a D-dimer can help rule out DVT, as a negative result makes DVT unlikely. However, a positive D-dimer doesn't confirm the diagnosis. It just means further imaging is needed. So in the case of a positive D-dimer, then you would move on to the venous ultrasound with Doppler. Moving on to the management, anticoagulation is the mainstay of therapy as long as there are no contraindications. First-line agents include direct oral anticoagulants called DOACs, like apixaban or rivaroxaban. Or, alternatively, low molecular weight heparin or warfarin can be used. Treatment duration should be individualized according to the presence or absence of provoking events and risk factors, while taking into account the estimated risk for recurrence and bleeding. In certain cases, such as when patients present with a massive DVT, thrombolysis or thrombectomy may be considered. And just a last little note here. Some additional considerations include ambulation and use of graduated compression stockings for the prevention of post-thrombotic syndrome. Now, preventing DVT is key. Patients undergoing major surgery should receive prophylactic anticoagulation when appropriate and encouraged to mobilize early postoperatively. Exercise, weight loss, smoking cessation, and use of compression devices also help. Patients traveling long distances should be advised to move their legs frequently and avoid prolonged sitting. Here are some key takeaways. Number 1. Unilateral leg swelling is a red flag. Always consider DVT in your differential. Number 2. D-dimer is great for ruling out DVT, but not for ruling it in. Confirm with ultrasound if there's suspicion. Number 3. Be cautious with anticoagulation. Assess bleeding risks before starting treatment. And number 4. DVT below the knee is less likely to embolize than a proximal vein DVT, but still requires appropriate management. All right, let's practice some clinical questions. Question 1. A 60-year-old man presents with left leg swelling and dull pain that started 2 days ago. He was recently hospitalized for hip replacement surgery, but is otherwise healthy. He denies chest pain or shortness of breath. On physical exam, the left calf circumference is 4 centimeters larger than the right. The leg is warm, and 2+ pitting edema is noted. No erythema is seen, and the unaffected leg is non-edematous. Which of the following is the most appropriate next step in management? Is it A, obtain a D-dimer test, B, perform a compression venous ultrasound, C, prescribe NSAIDs and observation, or D, start empiric anticoagulation without imaging? I'll give you a couple of seconds. If you chose B, perform a compression venous ultrasound, you are correct. The patient has a high-risk scenario for DVT. The recent hospitalization for major surgery, unilateral leg swelling with pitting edema, and significant calf circumference difference were all things that should have stood out to you. The next best step is a compression venous ultrasound to confirm the diagnosis. A D-dimer test is useful in low or moderate risk patients, but not in those with high pretest probability. Question 2. A 32-year-old woman presents to your primary care clinic with mild swelling in her right calf that she first noticed yesterday. She denies pain, redness, or warmth. She has no personal or family history of blood clots, recent travel, surgery, or hormone therapy use. She is otherwise healthy and active. Physical exam reveals a right calf that is 1 centimeter larger in circumference than the left, but there is no tenderness, erythema, or distended superficial veins. Patient has no signs of respiratory distress, and vitals are unremarkable. Which of the following is the next best step in management? Is it A, order a D-dimer test, B, perform a venous ultrasound, C, start empiric anticoagulation, or D, reassure and discharge? If you chose A, order a D-dimer test, you are correct. This patient is low risk for DVT based on her Wells score and lack of major risk factors. A D-dimer test is appropriate for ruling out DVT in low-risk patients. If negative, DVT is unlikely, and no further testing is necessary. Venous ultrasound is unnecessary unless the D-dimer is positive. Empiric anticoagulation is reserved for patient with a DVT, and reassurance alone is not appropriate without ruling out DVT. Great job! That wraps up our discussion on deep vein thrombosis. Remember, early recognition and prompt treatment are key to preventing complications like pulmonary embolism. If you enjoyed this episode, be sure to subscribe and leave a review. Stay tuned for our next episode where we'll tackle another important cardiovascular topic. And as always, this is the Pro PA Podcast, where future pros in medicine are made. See you next time.